Today we have the oral presentation where we presented data on a phase 2 trial of T-DM1 and Palbociclib in patients with metastatic HER2 positive breast cancer. There has been preclinical data which showed the benefits of CDK4/6 inhibitors in the HER2 positive tumors, and this was independent of the ER status. After the preclinical model where it showed that T-DM1 is cytostatic, but after it's treated, within about 48 hours, there is cell proliferation and viable cells escape the cytostatic effect and they start proliferating. So adding CDK4/6 inhibitors at that time led to prolonged suppression of those viable residual or resistant cells. Based on the preclinical data, there was a phase 1 safety study to look at various dose levels, and that led to our investigator-initiated phase 2 study. It was initially designed as a randomized phase 2 study with planned enrollment of about 146 patients. They were going to be randomized 1:1 to either the combination of T-DM1 with Palbociclib or to single agent T-DM1. The T-DM1 was going to be administered at 3.6 milligram per kilogram every 3 weeks as per standard of care guidelines or practice what we do. And Palbociclib was going to be administered at 125 milligrams orally from day 5 to 18. And this was selected based on the preclinical models where the CDK4/6 come into action when there's residual cells which escape the T-DM1 as such. So Palbociclib was administered from day 5 to 18 on every 21-day cycle. Dose reductions were allowed for both the drugs as per standard guidelines that we do. Like I mentioned, it was designed as a randomized phase 2 trial with planned enrollment of 146 patients. Our first site was activated in October 2018. Our last site was activated in May 2020. And as everyone is aware, in the interim, we had approvals of 2 drugs in the HER2 positive space in the metastatic setting. One is Trastuzumab deruxtecan, and we had tucatinib. And we had COVID-19 pandemic. All these 3 led to significant enrollment issues, and the study design was subsequently changed to a single arm of just a combination. We plan to enroll 46 to meet our primary endpoint of progression-free survival. However, after enrolling about 38 patients into the combination arm, the study was closed just to very slow and poor accrual. As we have seen previously reported data in the PATINA study, Monarch-HER, and others, there are roles of CDK4/6 inhibitors, and the PATINA trial did demonstrate benefit of adding CDK4/6 in the triple positive tumors. In our study, one of the key results we've noted in the combination arm were in the 38 patients in the combination arm, and we had about 14 patients in the single monotherapy arm. That was before, the study was changed from a randomized phase to single arm. When we look at the results, we see that about 3 patients in the combination arm had complete response, 12 had partial responses, and 15 had stable disease. So pretty impressive disease control rate and overall response rate. In the monotherapy arm, we did not we did not see any complete responses. There were 2 patients who had partial responses. So there is still activity of the monotherapy, but the combination arm did show significantly more activity. Now, about 66% of the tumors had ER positive status, and 53% were PR positive, and about 9% had CNS metastasis at enrollment. The progression-free survival in our study showed that in the monotherapy arm of the 14 patients enrolled, the PFS, the median was about 8.3 months, whereas in the combination arm, the median PFS reported was 16.9 months. I do want to highlight that we are not doing a statistical comparison because our study was not designed to compare, because the study design was changed and we have a significant limited sample size, but numerically, they are pretty significant, 8.3 versus 16.9. In our combination arm, when we did a subgroup analysis in the ER positive versus ER negative tumors, we saw similar progression-free survival. In the ER positive, it was 16.9 months. In the ER negative tumors, it is 17.1 months. Now, this is slightly, while the sample size is very small, it is hypothesis generating, saying that potentially CDK4/6 inhibitors could be in HER2 positive, irrespective of the ER status, unlike the other data which has been presented so far. Again, it is hypothesis generating, which need to be studied in a larger sample set. But it shows that potentially CDK4/6 inhibitors could be used in all HER2 positive tumors, independent of the ER status.